Margaret O'Donnell, Council Member, and Shirley, who have helped to put this together. And I'm particularly pleased to welcome, I see Conor Stapleton, a final year medical student from Trinity. So Conor, you're very welcome. Professor Michael Henderson. I don't believe Michael is live. I think it's a recorded interview. And then Derek Power, who's a consultant medical oncologist from CUH. And I remember hearing Derek present on the personalized treatment or targeted therapy for colorectal cancer at a meeting last year. And I have to say, Derek, it was one of the best lectures I've heard on the topic. So I will be all ears this evening and listening to you. So I'm going to sign off into the background now and ask Margaret, would she take over with Shirley and chair this evening's presentations. Thank you.
Thank you, Ronan. Thank you, President. And welcome to everybody to the meeting. I'm going to introduce Shirley to you, and Shirley is going to moderate the session. Conor, you can see online there. And as Ronan also mentioned, Michael Henderson's piece has been pre-recorded because of the time difference with Australia. But we have some questions and answers from him as well. And then we'll be following with Colin Power. Shirley, just to introduce you for those of you who don't know, Shirley is a plastic in the Mater University Hospital. During her training, she completed a PhD in tumour biology under the HRB Clinical Scientist Scholarship, and she was fellowship trained at Peter MacCallum Cancer Centre and the Alfred Hospital in Melbourne. She also went to the Gangnam Memorial Hospital in Taiwan. And her special interests are reconstructive microsurgery, head and neck surgery, advanced cancer, and melanoma. And she has a keen interest in surgical education, in particular microsurgical simulation. And some of you who tuned in early might have just heard some of the chat going on saying that those clinical skills trainings were still continuing this week. I should also point out that Shirley is currently still on maternity leave, and during all this time she's managed to be awarded the Irish Cancer Society Clinician Leadership or Clinician Research Leadership Award. And actually I'd be fascinated to hear a bit more about the research that you've done, Shirley, to be awarded that. So maybe would you just fill in the audience what you've been doing with that? And before we do that, could everybody who's watching please just turn off your cameras and turn off your microphones. Just turn off your cameras and turn off your microphones if you're not directly participating, just so that it doesn't distract the others. Shirley, can you fill us in on?
Sure, yeah. Thanks, Margaret, and thank you, Ronan, for the introduction, and thank you to everyone for tuning in. I'm excited to see that there's so many people interested in this topic because it's one that's close to my heart and one that I'm extremely interested in, and hopefully we'll put a good bit of work into over the next few years. So. Yeah, I recently was awarded the Irish Cancer Society Clinician Research Leadership Award, and this shows a lot of foresight from the Irish Cancer Society in that they've been very generous and have shown leadership in this area in that they have sponsored time for clinicians to be involved in research, so protected time where clinicians can lead on research projects. From my point of view, I will be starting this next year, and it will be in the area of melanoma. I have already started the beginnings of what hopefully will be a bigger translational research group between the Mater and UCD and Vincent's. I'm fortunate to be in strong collaborations with some excellent scientists in UCD, that would include Amanda McCann in the Conway, Des Tobin in the Charles Institute, and Pamela Kelly in the Veterinary College. So we're going to be looking at translational aspects of melanoma, in particular at extracellular vesicles, which are signaling molecules that travel in the blood of melanoma. Hopefully we will find them in melanoma patients and signal between the tumour cells and between metastatic sites in the hope of finding a therapeutic target for human melanoma or potentially some biomarkers. But we're also going to look at an interesting area of oncology called comparative oncology, which looks at animals that get diseases. And in Ireland, there are 40 to 50 dogs that get melanoma per year. and it's quite similar to humans. It becomes metastatic quite quickly, so it's a good model to look at, and we will hopefully get insights into human melanoma and have benefit to canine melanoma as well, so quite an interesting niche area. It's fortunate that we have the veterinary college on site with the medical college in UCD. But I'm delighted to be moderating this session today, and I might start by introducing Connor, who I see online here. We're really lucky to have Connor speaking. Connor is a final year medical student in Trinity College Dublin. Last year he was diagnosed with stage 3 melanoma and is currently receiving 1 year of adjuvant immunotherapy. Since his diagnosis, he's been very much a strong patient advocate, and you might have seen him on TV a few weeks ago. And he's especially interested in the area of access to adjuvant treatment, which I think is particularly important for Irish melanoma patients. So I might let Connor take the floor and carry on with his exciting presentation.
Good evening, everyone, and I would like to begin with a big thank you for affording me the opportunity to speak with you this evening. So my name is Connor Stapleton, and as was already mentioned, last year I was diagnosed with stage 3 melanoma. It just so happened that this coincided with my 4th year of medical studies in Trinity College Dublin. Next slide, please. The structure of my short talk today is as follows. So I'd like to begin by bringing you through some of the facts, figures, and epidemiology of melanoma in Ireland and across the EU. Then I'd like to share my own patient narrative, some of my own experience of being diagnosed with melanoma. And finally, I'd like to quickly address the issues around access to adjuvant treatment in melanoma in Ireland. Next slide, please. So, next slide, please. So, according to the European Cancer Information System, Ireland has the highest estimated age standardized incidence of the EU 27 in 2020, and that stands at 718.3 per 100,000. The most recent Irish figures come from 2015, and this shows that both in situ and invasive melanomas are increasing in number, and this is in contrast to many other cancers whose incidence are declining, but no such trend is evident in melanoma. Melanoma is one of the most aggressive human malignancies, and deaths due to melanoma have increased dramatically in the last half century, going from 16 a year in the 50s up to 159 per year in 2015. And finally, melanoma survival in Ireland is close to the European average, although this comes with the caveat that so much has changed in melanoma treatments in the last 10 years. And we hope to get more up-to-date info moving forward. So next slide, please. So here we can see the estimated incidence of melanoma by country. Ireland is shaded in the darkest colour, reflecting the high melanoma incidence in Ireland. Next slide, please. Fortunately, when we look at mortality, we are closer to the European average. We must remember also that the key to lowering both incidence and mortality for melanoma is by prevention. And that means us advocating in our professional lives some protection measures, but also in our own personal life and by being sun smart. Next slide, please. So now I'd just like to talk for a few moments about my diagnosis. So in early 2019, I first noticed a skin lesion on my lower left back, and I wasn't too concerned. It didn't have any scary characteristics. It wasn't pigmented. It was quite large, but I thought it was something like a skin tag. Didn't think too much more about it, and went to my GP in April. And then following consultation with my GP, she wanted to refer me on, but neither of us were too worried. And I got an appointment with dermatology for October of 2019. In the meantime, I went to Africa and spent 4 great weeks on elective in Zanzibar. But by the end of the summer, the lesion had begun to bleed, and I suppose that was the first real warning sign. Unfortunately, when the melanoma was removed, it was found to be a melanoma under the microscope, and then I was passed on the excellent care of Mr. Cronin in the Mater Hospital, where I had a wide local excision and a sentinel lymph node biopsy. Unfortunately, the sentinel lymph node biopsy was positive as well, so I had a PET CT scan, which didn't show any disseminated disease, but I had to have a groin dissection in January of 2020 before all the COVID happened. Next slide, please. So we can see on the top left, this is a short answer question taken, screenshotted directly from my third year pathology exam. Nice broad question, discussed malignant melanoma. Well, I thought so at the time anyhow. I answered this question, was quite happy with myself. But little did I know that in December 2020, I'd be talking to you today after receiving 21 doses of nivolumab for adjuvant treatment of melanoma. Next slide, please. So these are the facts, and that is my story, but what has this experience taught me? So I turned to someone a bit more eloquent than myself to try verbalize some of these thoughts. I picked out this quote from When Breath Becomes Air. I'm sure it's a book that many of you have read, by Dr. Paul Kalanithi, and I'll just like to read that quote now. So I began to realize that coming in such close contact with my own mortality had changed both nothing and everything. Before my cancer was diagnosed, I knew that someday I would die, but I didn't know when. After the diagnosis, I knew that someday I would die, but I didn't know when. The fact of death is unsettling, yet there is no other way to live. Uncertainty followed me in the weeks following my diagnosis, especially as I was staged, and my mind wandered down lots of dark paths. But the thing that stands out most clearly from the time was the kindness and the small gestures that I received in that time. The popular idiom, nobody knows, or people don't care how much you know until they know how much you care, came into my mind a lot during those days, and certainly still echoes in my mind when I see patients as a medical student. Right. So next slide, please. So I'd like to finish on a few points around adjuvant treatment of melanoma in Ireland. So currently in Ireland, in the public system, you cannot access targeted therapy or immunotherapy after a stage 3 melanoma diagnosis. You can see from this graphic here I created over the summer with the help of the MP&E that this is not the case all throughout Europe. Adjuvant treatments have been evaluated for cost effectiveness by the National Centre for Pharmacoeconomics, and they have found that it should be considered for reimbursement if cost effectiveness can be improved relative to existing treatments. The existing treatments that they discuss is active surveillance, and surely we can do better in 2020 than simply watching and waiting. One of the measures that the NCP used when evaluating the cost effectiveness of a medicine is the incremental cost effectiveness ratio. The incremental cost effectiveness ratio for nivolumab comes in at €52,000 per quality, which just falls above the €45,000 per quality arbitrary guide or bar that they set for recommending reimbursement to the HSE. So I think it's my personal duty as a melanoma patient and our collective duty as healthcare professionals to advocate for melanoma patients and see that they receive the best possible care. Next slide, please. So I'd just like to finish with another thank you for listening to me today, and I hope you enjoy the rest of the talk.
Super. Thank you, Conor. Thanks for giving us such a personal overview, and thank you for sharing your story with us. I might just ask you one quick question and then ask you to stay online if that's okay for any questions that the audience may have at the end. So given that we see the much better survival of melanoma patients because of the improved treatments recently, what do you think might be the main survivorship issues in the melanoma patients, given that they're hopefully living a lot longer?
I suppose the way I'd answer that is the same way I try to answer questions, or to teach us to answer questions in medical school. So I'd break it down into the psychological impact of living with cancer, and living often with a stage 4 diagnosis can be huge. From talking to people, this is a huge issue, and I think there's scope for psychological supports moving forward. And then from a physical point of view, I know even personally, I used to love playing football and going for runs, but because of recurrent cellulitis after my groin dissection, it's been a bit difficult to change the way I exercise. But there definitely could be more work done in the future about effective both psychological and physical interventions for those survivors of melanoma.
Great. Thank you, Conor. I might ask you to stay online if that's okay, if you have time.
Perfect. Yeah.
Super. Thanks.
Shirley, before you go on, can I ask that others who are not participating just turn off their cameras so that it gives a full screen to the speaker? Thanks.
Okay, thanks, Ronan. So I'd like to introduce our next speaker. It's Professor Michael Henderson. Michael is the Professor of Surgery at the University of Melbourne and a surgeon in melanoma, breast and sarcoma at the Peter MacCallum Cancer Centre in Melbourne, where I was fortunate enough to work alongside him. He was fellowship trained in MD Anderson. Melanoma forms a large and major part of his workload, and he has been involved and an author on recent practice-changing trials around melanoma sentinel node, and is going to talk to us this evening about the debates around margins of excision for melanoma.
Well, good evening, good morning, good afternoon, wherever you are. My name is Michael Henderson. I'm a surgeon in the melanoma unit here at the Peter MacCallum Cancer Centre in Melbourne, Australia. And it's a pleasure to be able to speak to you today. I want to say a special hello to Shirley Potter, who has asked me to do this presentation. We remember her fondly from her time in Melbourne, and we did our best to keep her, but obviously there was something more happening back at home. So on with the show. Let's go. Next slide, please. I have no disclosures. Next, please. So the whole business with melanoma started with Samson Handley years ago, and it's fair to say that he had a very radical approach to the management of melanoma, and over the subsequent 120 or 30 odd years, there has been a considerable de-escalation in the extent of the margins for surgery for melanoma, and at this stage we still are in a position that we really do not have definite evidence about what is the acceptable or the most appropriate margin for the management of cutaneous melanoma. Next slide, please. The aim of treatment of the primary melanoma is to remove all the melanoma that is there, and perhaps anything that's potentially there that you're not aware of, that is occult disease, with the greatest chance that there will be no evidence in the future of local recurrence or dissemination. Now, there are two basic ways that a local recurrence can occur. Either there's something left behind or something's come back. Next slide, please. If we look at the factors that are associated with recurrence of primary melanoma, then they essentially fall into two groups. There are those that suggest that it's due to an intrinsic features of the primary tumour, that is the biological aggressiveness, and classical examples of that are tumour thickness, ulceration, and lymph node involvement. On the other hand, there are other prognostic factors for local recurrence which suggest the presence of further disease around the primary tumour, specifically satellites, perineural invasion, and the unusual, but we do see it in Australia, desmoplastic melanoma, which is a form of melanoma that we see not infrequently and increasingly so in older Australians in sun-affected area. Next slide, please. So when we talk about local recurrence, there are some who actually claim that they can pick the features of a primary melanoma that are likely to occur because there's likely to be disease around it. And I'm not just talking about the presence of satellites or perineural invasion, seems to be related to the morphology of the melanoma. Now that's highly contentious, and I don't actually strongly believe in that. The alternative is that the melanoma is an aggressive lesion which somehow or other has metastasized prior to discovery and wide excision, and the primary tumour site reflects an area that the melanoma metastasizes back to. Now that does sound a bit bizarre, but in fact, if you consider many patients with melanoma, then it is not uncommon that development of local recurrence it either occurs simultaneously or even after the development of metastatic disease. Now, these lesions tend to be more so in the more advanced cases of primary melanoma, that is determined by tumour thickness and ulceration. Next slide, please. So where do we stand as far as the evidence concerning margins for excision of melanoma? In 2010, Mike Sladden, who's from Tasmania and an international cast of stars, performed a very extensive Cochrane review. At that time, there were 5 randomised controlled trials which have approached the issue of margins of excisions for melanoma. Now, they compared, at the end of the day, 1 and 2 centimetres as a narrow margin versus a wider margin of 3 to 5 centimetres. And the meta-analysis actually suggested that there was no difference in overall survival, but there was a small advantage in terms of local control for the wider margins. So this tends to speak to this issue that most local recurrences are probably related to persistent disease, and that persistent disease is probably intralymphatic. And it's actually very interesting. If you look at the new AJCC staging system, which is now 2 or 3 years old, that is a local recurrence within 5 centimetres of the scar, in-transit recurrence, and a true local recurrence in the wound are all considered to be related to the same mechanism, that is lymphatic emboli, and all have exactly the same prognostic significance. And that's why they are classified in a similar way in the new AJCC staging system. Now, as of November 2020, there are now 6 randomised controlled trials. And 2 of the reports have extended follow-up, which I'll show you, at least 5 meta-analyses, including as well as the Cochrane review, and a Bayesian analysis. Now, all except the last, the Bayesian analysis, and a number of virtually all the non-randomised studies, cohort studies, indicate that smaller margins are not associated with worse survival. Next slide, please. Now, this slide shows you the randomised trials which have been reported to the present time. And there are 6 of them, and they go back now for nearly 40 years. And you'll see that the numbers in the studies are relatively large, but not excessively so. The problems become a little bit more obvious in looking at this data. And when we look at the margins of excision that are examined in these studies, and they vary from 1 versus 3 to 2 versus 5, etc. And furthermore, when you look at the patient population, the thickness of the melanoma is selected in some of the series, not in others. And then finally, the site of the melanoma. Most of the studies accepted melanomas on the trunk and limbs, but the digits and certainly the head and neck were not included in these reports. Now, interestingly, the rate of local recurrence is actually very low in these studies, and that's certainly the experience that one has in clinical practice, and it varied between 0.5% and 3%. The survivals that were reported do not show any difference between the patients who received a smaller margin compared to the wider margin. And the follow-up is really now looking to be pretty good. The French and the Swedish studies have reported updated results in the last 2 or 3 years, and they clearly indicate out at 16 and nearly 20 years that local recurrence, most of them are going to occur relatively early in the natural history of a patient with melanoma. Next slide, please. So let's just summarise that data. There have been 2 studies which have compared 2 centimetres versus 5 centimetres. First of all, no difference in overall survival. One study has compared 2 centimetres versus 4 centimetres, no difference in survival. For 1 centimetre versus 3 centimetres, there have been 2 studies performed, and those 2 studies looked at patients with melanomas less than 2 millimetres in thickness. No difference in survival between the thin and the wider margins. However, the UK study, which looked at patients with melanomas over 2 millimetres in thickness, the results are a little bit inconclusive. And there are some issues with this study that we can discuss if we want to at a later stage as to why I think this is probably not going to change what I'm going to tell you a little bit later on. Next slide, please. I've chosen here three studies which are retrospective studies to illustrate some of the issues, and they all come from the Melanoma Institute of Australia. The first study is an older one, but it looked at melanomas less than 2 millimetres in thickness, and if the pathologist measured at least 8 millimetres of normal tissue around the melanoma, and an 8 millimetre pathology margin is equivalent to a 10 millimetre margin after allowing for shrinkage, there was no difference in local recurrence. So adding wider margins beyond 1 centimetre for melanomas less than 2 millimetres did absolutely nothing. For melanomas 2 to 4 millimetres thick, a similar margin, 8 millimetres pathology, equivalent to a 1 centimetre margin, but with the addition of a sentinel node biopsy, gave them the optimal chance of disease-free survival, overall survival, and regional node control, as well as there was no difference in transit-free local recurrence and transit-free recurrence. Now, this study actually, as did the following one, the 4 millimetre thick study, was based on the Sydney Melanoma Unit's experience, where previously they had not done sentinel node biopsy, but for the 2 to 4 millimetres, had done a 1 centimetre margin, and for the greater than 4 millimetres, they'd done a 2 centimetre. They found their results were improved in the more recent patients when sentinel node biopsy had been performed, and that's one of the issues that a lot of people have with the UK study, is that sentinel node biopsy was not incorporated in it, and as I showed you before, it's a predictor of local recurrence, probably because of this issue of the biology of the tumour. The local recurrence rates are not particularly different, but it's the overall survival, which would be consistent with this idea that it's the tumour burden that's the overriding factor that determines patient outcomes, that is survival, and to a lesser extent, the incidence of local recurrence. Next slide, please. Now, you would have thought that based on all this data, there'd be a fair amount of consensus about how we should manage primary melanomas as far as margins are concerned. Now, this is a slide that summarises the current international guidelines for the management of primary cutaneous melanoma. And as you can see, for in situ melanoma, everybody's happy with a 5 millimetre margin, except that's probably not going to be right for some people. But that's for another day. For melanomas less than 1 millimetre in thickness, T1 melanomas, everybody agrees that a 10 millimetre margin is appropriate. Now, the trouble starts when we start looking at thicker melanomas. And if we look at the T2 melanomas between 1 and 2 millimetres in thickness, the Germans recommend, as they are often more definitive than most of the rest of us, that a 10 millimetre margin is acceptable. But everybody else in the world has basically thrown their hands up and says, well, you can do somewhere between 10 and 20 millimetres. They don't actually tell you when you should do a 10 and when you should do a 20, or whether a 15 is the way to go. But that's the take from most of the international guidelines. T3 melanomas, even a little bit more controversial. We've got 10 to 20, 30, 20 to 30, etc. And when we look at T4 melanomas, everybody agrees that a 2 centimetre margin is appropriate, except for the UK group who think that a 3 centimetre margin is appropriate. Next slide, please. When we talk anecdotally to colleagues around the world, quite a few people have actually started margins that they currently practice with. And if you corner surgeons and say, if you've got this particular situation, would you do a 1 centimetre margin for this T3 or T4 melanoma? Because if you didn't, you'd sacrifice a major structure or cause a lot of cosmetic harm. And virtually every one of them will say, yeah, of course I'll do the 1 centimetre margin. So there's actually a lot of 1 centimetre margins being done all around the world. And we've not seen a great signal in terms of poorer outcomes in terms of local recurrence or survival. So why are the margins important? If we look at 1 centimetre versus 2 to 3 centimetre, obviously there's increased morbidity from a bigger incision. And it's not just the fact that you've got to do more likely to do grafts and flaps. Just the bigger operation means more morbidity, greater rate of wound infection, wound dehiscence, etc. The cosmesis, no arguments about that. Increased requirement for reconstruction. I'll show you some data that suggests that it's actually quite significantly more. You're going to commit more and more patients to inpatient stay rather than an outpatient procedure. Increased discomfort. And more recently, a number of groups have reported chronic long-term pain in patients, seen more commonly in patients who've had obviously more greater excision margins. And of course, the cost to the patient, both psychological and financial, things such as simple things as patient reported outcomes that they didn't enjoy the surgery, through to it took them longer to get back to work, it had a greater effect on their earning capacity, etc., etc. Next slide, please. This is some collected data, quite a lot of people, just to show you that the need for reconstruction was at approximately double when you went from the 1 centimetre margin to wider margins. The incidence of skin grafting went up quite considerably. In the head and neck, it was worse, and it was a little bit less. Well, in fact, it was significantly less for lesions on the extremities. Next slide, please. So that brings me, for one of the reasons I was very keen to talk to you tonight, is that based on experience around the world, a review of the data, the fact that we are de-escalating margins has led us to propose, initiate, and actually have funded what's known as the Mel-MarT trial. It's a phase 3 multi-centre randomised controlled trial investigating 1 centimetre versus 2 centimetre margins. Next slide, please. The primary objective of this study is to look at local recurrence rates and melanoma-specific survival for patients with melanomas greater than 1 millimetre in thickness where it's ulcerated, or greater than 2 millimetres in thickness for all other patients. Next slide, please. The secondary objectives are related to patient outcomes, quality of life, long-term symptoms, and there is an economic analysis as well. Now, this is an equivalence trial, so we're trying to show that in fact it provides equal outcomes in terms of the primary objectives between the wider and the thinner margin, that is 2 centimetres versus 1 centimetre. But we see benefits in terms of improved quality of life, better patient-reported outcome measures, and reduced financial cost to the government. And when we did some modelling that allowed us to have this study funded by the Australian government in Australia, it was invariably the fact that we were going to knock off several $100,000 worth of health expenditure by the government a year if we could reduce the margins from 2 centimetres to 1 centimetre. The other thing I've got to say about this study is that it will probably never be repeated. The NCI had a go at funding a study very similar to this, or at least a decade or so ago, and it never really got off the ground. There's a lot more enthusiasm for this study now, and no matter what the result is, it's going to determine what we do. If we can prove that 1 centimetre margins are equivalent to 2 centimetre and wider margins, then that will become the standard of care. If we can't show that that's the case, and that then 2 centimetre margins will remain the standard of care for those melanomas that we're randomising in the study. Next slide, please. This is the study schema. I've mentioned to you that it's stage 1B to 2C, that is greater than 1 millimetre that's ulcerated, or greater than 2 millimetres ulcerated or not, and randomised with the appropriate stratification to 1 centimetre wide excision plus a sentinel node, or 2 centimetre wide excision plus a sentinel node. Next slide, please. We have performed a pilot study. We randomised 400 patients to a 1 centimetre or 2 centimetre margin. We found what had been previously noted, that the 2 centimetre group were more likely to require reconstruction, and there was more wound complications. Interestingly, after an initial deterioration in quality of life in both groups, probably a little bit more so in the 2 centimetre margin, by 12 months, the groups were essentially equivalent and had returned to normal. That is, there was no difference, but the patients were essentially back to their previous functioning status. The health economic data and outcome data are not available at this stage, and will not be for some time, particularly as we need to follow these patients for a number of years yet. Next slide, please. So the Mel-MarT study is now open to recruitment. The Australian Government, National Health and Medical Research Council project grant. It's funded. Unfortunately, the funding is limited to patients treated in Australia. It's a multi-centre, multinational randomised trial. We have colleagues in New Zealand as well as Australia undertaking this study. My colleague Mark Moncrief in the UK is spearheading their program to get this up and funded. Josh Mammon in the US is pushing it through SWOG, and the Canadians through Francis Wright from Toronto have managed to secure funding for this study. So it's occurring in all around the world. And I'm hoping that our colleagues in Ireland, if they've got some interest, you'd be most welcome to join us. You can flick me an email. My name's Michael Henderson, michael.henderson@petermac.org, or I'm sure Shirley would pass on your details to me if needs be. I think at this stage I'll stop, and I understand we're going to have some questions for a while. Thank you.
Okay. Thank you very much, Michael. That was super. It's always an area of controversy in our MDTs, and that guidelines give you, do 1 versus 2 centimetre margin and make your own decision. And it does have a significant impact on patients, especially when in the head and neck area, when there's cosmetic outcomes at stake, and also post-operative pain, and in particular, day case surgery versus inpatient surgery, with the current pressures on the system, and particularly with the current pandemic ongoing, it's much harder to get these patients in. So if you can do a 1 centimetre margin and get them in as a local anaesthetic or a day case, it's a no-brainer without affecting survival. So we have had a couple of questions, if that's okay. A couple of them pertain to margins, and then we might move on to a little bit about sentinel node and the MSLT2 trial, which you were involved in as well. First off, with regard to head and neck melanoma, and considering that survival is worse, in particular things like the scalp and the ear, would you be happy with a 1 centimetre margin for something like a 2.5 millimetre melanoma with ulceration? It's kind of counterintuitive because we know that these are high risk melanomas, and we see a lot of them in Ireland with sun exposure. So I wonder, would you be happy with the narrow margin in that area?
Okay, look, so then let me answer that question by saying in the Mel-MarT study there are 3 groups of patients that are excluded: patients with microscopic satellites and patients with perineural invasion, both of whom have a much higher rate of local recurrence. The 3rd group is desmoplastic melanoma, and they have a much higher rate of local recurrence as well, and it's partly due to the fact that they have an increased risk of perineural invasion compared to other forms of cutaneous melanoma. So talking about this patient with a T3 melanoma that's not got any of those features, I would be happy to randomise them in the study. If you were to do a 1 centimetre margin, however, you would be going against the currently accepted guidelines. And in this country, if you went against the guidelines without making sure the patient knew and you had a good reason for doing it and something happened, you could potentially find yourself at risk legally. So that's not a good answer, but I would have no problem in randomising this patient within the study. Would I ever do a 1 centimetre margin? Of course I'd do it, but it'll be for the elderly patient that you want to avoid some sort of flap or graft or something like that, and it's a pragmatic decision. So I'm happy to randomise patients is the answer I've got to stay with.
Okay, very good. You mentioned desmoplastic, and I know it's not in the trial, but do you have guidelines or how do you treat desmoplastic in terms of margins? Because we know it's way more aggressive. Yeah, well, we always have an argument about whether it's a pure desmoplastic melanoma or a mixed desmoplastic melanoma, and if there's a significant component of it has to be nearly completely desmoplastic, rather than some features of non-desmoplastic, the so-called mixed. And there are some slight differences in terms of the natural history. The pure desmoplastic melanomas are probably less likely to go to sentinel nodes than the mixed desmoplastic melanoma. So we would do a sentinel node biopsy, but we would also have a very good look at the pathology, and we would review it ourselves to make sure there's no perineural invasion. Our experience with perineural invasion is disastrous. I'm not talking about the tiny nerve that there's a little spot of tumour in it. They're generally handled reasonably well by a wider excision. But where you've got a big nerve or a named nerve with obvious tumour in it, and they can be skipped sort of lesions. You may not see it extending in continuity. That predicts a very high rate of recurrence, even when people take out the nerve, etc. So as a matter of course, we will do a wide excision, and the wide excision would be a minimum 2 centimetres. And in certain situations, we would also consider adjuvant radiotherapy as well. However, we are becoming a little less aggressive in our surgical and radiation management of patients with desmoplastic melanoma, because desmoplastic melanoma is really a good melanoma to treat with the new immune checkpoint inhibitors. And it's probably got to do with the fact that they have a very high mutational burden related to UV exposure, and the vast majority of patients will respond to single agent anti-PD-1 therapy. And we actually factor that now into our decision making when we talk about desmoplastic melanoma, knowing that the patient, if they did develop further metastatic or recurrent disease, then we have a very solid backup treatment in anti-PD-1 therapy. Excellent, thank you. And then the final question around margins. We know that melanoma is a very heterogeneous disease. There's lots of prognostic factors we look at. Do you think Breslow thickness on its own is enough to base our margin decisions on, or should there be other biological features we look at?
Well, apart from desmoplastic melanoma, perineural invasion and microsatellites, they're the major ones that I would look at. Otherwise, it's tumour thickness, and it is the strongest predictor recurrence, local recurrence, although tumour ulceration is up there, and of course lymph node status as well.
Very good. So Michael, you were one of the key authors on the MSLT trials, and our practices have changed everywhere, all around the world, including here in Ireland, around whether we do completion lymph node dissections after a positive sentinel node for melanoma patients. Every week, almost in our MDTs, there's questions around this and controversy. So I think if it's okay, I might ask you a couple of questions that have been submitted around that topic as well. And this is one that comes up a lot with regard to head and neck melanomas, which would have been almost underrepresented in MSLT2 and excluded in the DCOG trials. Do you treat these patients differently if they come back with a positive sentinel node in terms of ultrasound surveillance? Would you have a lower threshold for doing something like a neck dissection, and do you have a way of deciding which ones you might go ahead with?
Look, that's a really good question, and the answer is that at the present time we would treat head and neck melanomas similar to elsewhere. Now, if you look at head and neck melanomas, the thing that really leaps out, and we've just looked at some of our own data, and that is that doing the sentinel node biopsy is really hard, and it takes a significant amount of expertise, not just to the surgeon but the nuclear medicine physician in helping you to undertake the procedure. Now, what do I mean by that? Well, John Thompson up in Sydney demonstrated quite a few years back that head and neck melanomas go all over the place. And he loved to show this sort of party trick of a patient with a melanoma on the back of the neck, which went to both parotids, a level 1 node on one side and a level 3 node on the other. It just went on and on and on and on. He had about seven lymph nodes. And we know that the lymphatic drainage in the head and neck is really complex. So unless you're prepared to do that then and do it properly, then I think you've got to be a little bit circumspect. So we would do a sentinel node biopsy. We always go and talk to the nuclear medicine people to make sure that we're getting the right information. The biggest trap I've found is that because the lymph node basins are so close to where the primary site is, that you get a massive blast of radiation and you actually can't see the tracking or the sentinel node immediately adjacent to the primary site. So when I when I do my resection, I then look very, very carefully and beneath and around where the primary's been to make sure I'm not missing a local node. And I've got to say that's been our problem. So if we have got a positive sentinel node, we will then do the MSLT type ultrasound surveillance. Now, again, the lesson we've learnt, and I've heard this from other colleagues around the world, is that the ultrasonography to follow up the lymph nodes is not something for everyone. It's got to be done by someone who's got some experience. And so it should be done in a centre that's got some interest in it. And we do it 3 monthly for the first 2 years and then 6 monthly out to 5 years. We've not had any patients go ballistic, that is progress between appointments, particularly after 2 years. And generally we've been reasonably happy with our approach as far as sentinel nodes are concerned.
Excellent.
That's the question. And I must say, I was just one of the workers in the field for MSLT too.
In Ireland, we're unfortunate in terms of melanoma that we don't have adjuvant treatment for stage 3. We do have for stage 4. And a lot of these patients, if they come back with a positive sentinel node, we have a difficult discussion to have. So do you think in that setting, would there be ever a role for a completion lymph node dissection in the setting of a positive sentinel node? Just say, for example, a 35-year-old man with a 3.5 millimeter nodular with ulceration, who's had this melanoma on his trunk, a positive sentinel node with 2 nodes positive, one of them with a 12 millimeter deposit with extracapsular spread. given that there would not be an access to adjuvant treatment?
Look, the 12mm deposit is probably palpable to see. And, you know, one of the issues, I saw a couple of weeks back, a lady who was morbidly obese who I fished a node out of her groin. And when we got in there and had a look, it was pretty obvious that she had this 2-centimetre node. And that's a different deal from the patient who's got a true sentinel node. You know, and we know that 80% of the patients in MSLT2 had deposits less than, MSLT1 had deposits that were less than 1 millimetre or 2 in size. And we know that 75% of the people who got a completion lymphadenectomy in MSLT2, there was no further disease found in the non-sentinel nodes in the completion lymphadenectomy. So you're going to do an awful lot of lymphadenectomies and cause an awful lot of morbidity to have any benefit at all. So my answer would still say the same. We would, even in the absence of adjuvant therapy, I would still do ultrasound surveillance and operate on the patient if they got a further recurrence in the lymph nodes, and hopefully detected only by ultrasound.
Yeah.
Okay. And you know, the outcome for those patients, and you've got to remember that MSLT2 was done in the era before the immune checkpoint inhibitors and targeted therapy, essentially, or the vast majority of patients. The outcome between the patients who got a completion lymphadenectomy and those that didn't was identical. And I remain very concerned about the morbidity of lymphadenectomy. And particularly if you're in obese patients, and particularly if there's radiation, and if you combine the both, then the morbidity is frightful. And we've got to the stage now of basically abandoning adjuvant radiation to the lymph node basin.
Okay. Yeah, I have to say I am probably in agreement with you. Although I was a skeptic at the start and more pushing towards completion lymph node dissection, when you do that, it just comes back again, and you're adding to the morbidity of the patients, and not changing anything in the longer term. Melanoma is a tricky disease. The circulating tumor cells are seeding before we have found them, I think, and that's the problem. They've gone past the lymph node, or they're seeding in parallel. And then just one final question. It's regarding a recent paper that you're an author on with regard to challenges in implementing changes to clinical practice, like these guidelines, which have been rigorously tested and put through an evidence base. And it's seen that doctors can be slow to adopt them, and we probably see that in general on the ground. Do you have any advice about adopting guidelines into clinical practice, or if margins were to change in terms of guidelines for that, or any pointers as to how to implement things?
Look, that's a really great question, and it's obviously one that a lot of people have given a lot of thought to over the years. And I think we all have a responsibility to our patients and ourselves, and ultimately to our institutions and registration boards to keep up with the latest. But for people who don't do a large amount of melanoma or other diseases, you know, then you would not want to put yourself out of your comfort zone. So, you know, I think the idea of discussing cases with colleagues, and I think the idea of multidisciplinary teams and you know, those environments where you've got people coming together, all got a little bit of information, you know, is really, really ideal. It's a difficult issue. How you actually change people's practice, is difficult, and a number of people have tried various things. There's a whole lot of educational psychology out there in terms of rewarding people, but by far the most important thing to do is to actually educate people, to give people the opportunity to see the data, have the ability to discuss it, and then think about how they can bring it into their own practice. You You know, so sitting at home reading a journal article is not necessarily going to work, but working with colleagues through an MDT where there is ongoing discussion about what's the new and best is probably the way to go.
Yeah, I think in that scenario, when you're trying to change practice that you know is evidence-based, you really are doing the best for the patient. So that's the underlying theme in everything. Super. Well, Michael, I think we've taken up enough of your time, and we really appreciate your dialing in this evening. And it's great to get the opinions from somewhere that deals with so much melanoma. We deal with a significant amount here, but by far and away, we know that the picture is painted from Australia, and we kind of toe the line afterwards. And we're really appreciative of your time. So given the time difference, we don't have Michael online, although he did offer to get up at 5 a.m. and talk to us. I've told him maybe the extra hour in bed might be more useful. So now I'm going to introduce our next speaker, and we're really lucky to have Derek Power online. Derek is a busy man, so I think we're very fortunate. Derek was initially Jewish from Trinity and then proceeded on to get a medical degree from RCSI. He completed his medical oncology training in Memorial Sloan Kettering and was appointed as a consultant in medical oncologist in the Mercy in Cork and Cork University Hospital in July 2010. His interests include melanoma, gastrointestinal and genitourinary cancers, as well as familial cancer genetics. He has over 90 citations in international literature and has co-authored 5 book chapters. And he's currently the chair of the Melanoma Disease-Specific Subgroup in Cancer Trials Ireland and principal investigator on several large clinical trials. So I'll hand it over to you, Derek.
Thank you very much, Shirley. I'll just share my screen there. Can you hear me? You can hear me okay?
Yeah.
Fantastic, great.
Perfect.
So I'll start. So thank you everyone, and thank you Shirley for asking me to speak. So I'm a medical oncologist, as Shirley said, and I'm going to talk primarily on the role of neoadjuvant treatment, which is a new area, a real hot topic in melanoma. So to set the scene, melanoma is a surgical disease. I mean, I'm talking to the converted here, but the big problem is stage 3 and stage 4, which stage 3 is significant risk of recurrence, especially 3C, and stage 4 obviously is advanced and technically incurable. So in my world in medical oncology, this was a grim landscape, a very barren desert years ago. And a prominent dermato-oncologist from Germany actually said this only 11 years ago. So it's hard to believe, and it's amazing how far we've come. So we've come this far for many reasons. We know a lot now about genetics, sequencing of tumors, and melanoma led the way really in harnessing the potential of BRAF. So everything on top here is a tumor, and you can see BRAF mutations are very common in melanoma, unlike some of the other genes that you can see there that are turned on. Many of these genes are targetable. So BRAF is at the center of the proliferation, angiogenesis, survival, invasion, etc.
Derek, can you go to show the slideshow, because we're just getting the whole.
Oh, you're not seeing my. Can you see now?
No, if you can share your screen, but go to slideshow before you share your screen.
Oh, okay. Now, can you see now?
Yes, and if you now go to slideshow from current slide or from beginning, and it'll open out.
Is that okay now? Could you see now?
You're not in slideshow mode just yet.
Okay. There, I'm in slideshow mode now on my own computer. This is the way it normally works for me on this format. No?
Well, that's okay. It can still work for us here. Yeah, we can see the main slide. Yep.
Is that okay now?
Thank you.
Okay. So can you see that now, Shirley and everyone?
Yeah, we can see it now.
Okay. So that's the targeted agents I'm going to talk about in a second. I'm setting the scene here for neoadjuvant. So obviously immunotherapy is the hot topic, and we've come a long way in the treatment of melanoma from crude surgery, crude radiation, crude chemotherapy to much smarter surgery, smarter targeted agents, and of course immunotherapy that I'm going to talk about. So immunotherapy
Sorry to cut across you again, Derek. We're still stuck on the trend in incidence. There we go.
This is frustrating.
Have you uploaded your slides for RCSI? Pauline, do you have the slides at RCSI?
Prof, no, I don't have them here.
Okay. Have we lost Eric?
Maybe he can dial in again.
Yeah, I can't see him in the attendees right now, so maybe he has logged off and is trying to come back on.
Shirley, do you want to just take a couple of questions while we're waiting? There were a couple of comments. Oh, here he is. Okay.
Perfect, yeah.
Hi, Derek. Welcome back.
Can you see my slides now?
We can see slide 8. Yes, we can.
Yeah.
Basic mechanisms of T-cell stimulation.
Okay, so if I go to from the current slide, custom slideshow from the beginning. Now, can you see now?
No.
We're still seeing your sidebar slides. Yeah.
Okay. I may as well go like this because it seems to be there's a problem with the full slideshow. I don't know why.
Yeah, if you can manually pass them on or click on, that'd be great. Yeah, we're seeing. Yeah.
Okay.
Okay, well done. Thanks.
Okay, great. Sorry about that. So how the immunotherapy works is based in a cartoon like this, which is ubiquitous in the literature now. The interaction between the T cell and the tumor, which is essentially antigens on the antigen presenting cells. So I'm going to talk a little bit about ipilimumab, CTLA4 antibodies, and PD-1 antibodies. So the human system, the human immune system, in a way, is the ultimate anti-cancer treatment, and I'll outline this briefly. But we have to be very careful. This is not for every patient, immunotherapy or targeted therapy, and I often think this is a good slide to show in talks like this. We get very excited about a new technology. We have probably inflated expectations, and then ultimately we lead to a plateau of productivity. And this could be applicable to anything, radiology, surgery, and medical oncology. So the field is now awash with literature for advanced melanoma with big benefits in many of the different agents I've alluded to. Ipilimumab has about a 20% 10-year survival in advanced melanoma, which is quite amazing. This man here, Jim Allison from MD Anderson, has won the Nobel Prize 2 years ago with the Japanese investigator for discovery of CTLA4 antibodies. And of course, as Connor in his great talk alluded to, the newer drugs, the PD-1 antibodies, nivolumab and pembrolizumab, have really taken center stage now. And these drugs are better than ipilimumab. Pembrolizumab is better than ipilimumab for advanced disease. And the literature, the scientific literature, has many sensationalist titles like this is the writing on the wall for cancer. The pivotal study with combined immunotherapy is this study, Checkmate 067, and this looks at ipilimumab and nivolumab together, and it's powered to compare against ipilimumab. And this study really has changed the field in the utilization of immunotherapy in advanced disease. So at 2 years, 64% overall survival, and amazingly at 5 years, 52% overall survival for advanced melanoma. And who would have thought that would have been the case 11 years ago when that comment was made? So the KM curves are rising and rising with immunotherapy, and they're flattening. They're flattening years out, 3 years, 4 years. We have 10-year follow-up with ipilimumab, as I mentioned. So the melanoma landscape in advanced disease is becoming very packed with many different drugs. Immunotherapy, I've mentioned, the targeted therapies equally, combining BRAF and MEK inhibition. This is a feature article in the New York Times when I was in Memorial, and PET scans like this, full of metastatic disease, can be rendered metabolically inactive by BRAF inhibitors. The BRAF inhibition strategy is not durable. This is why MEK inhibitors were also discovered. And there is a significant subset of patients who have prolonged durable response and increased survival with BRAF and MEK inhibition. There are 3 randomized trials showing this. I've shown one earlier. This is the second one. This is COMBI-V. And then the third one using other agents. And these drugs have very powerful activity. Here's an example of a melanoma in the left flank that has been resected multiple times and has come back. And with drugs alone, this patient here got 5.5 years out of these drugs with an excellent quality of life. So there's consistent results across all these 3 studies that I mentioned, to such an extent that titles like this in the New England Journal of Medicine have been published as long ago as 10 years. So what about long-term follow-up with BRAF and MEK inhibitors? Well, 34% 5-year survival in all comers is very, very respectable and very impressive. It's not quite the 52% 5-year survival for immunotherapy, however. If you take subset analysis on low LDH and less than 3 organ sites, you can get up to 55% 5-year survivals, and you could get even higher in those patients with predefined subset analysis of these studies who have a complete response. So now we have many, many agents that are approved on both sides of the Atlantic. These are the FDA-approved drugs. And bear in mind, up as recently as 1998, there were really only 2 drugs. So how the field has changed. So we have very complex decisions to make in advanced disease. I'm not going to go into all of this in great detail. And this is now big topics of discussion at meetings. And these are good problems to have. What's the best sequence? What's the best combination? And many trials are ongoing to look at that. What about adjuvant treatments? Well, equally so in adjuvant treatments. And Connor spoke about his wonderful experience with adjuvant treatment. So years ago, not that long ago, in fact, all we had was interferon, which is a very toxic blunderbuss drug that really didn't benefit patients. In retrospect, you'd have to question. So now we have these other drugs that I've alluded to in the advanced setting that have been studied in the adjuvant setting. So our surgical speaker before me has outlined the controversies in the surgical management of melanoma, which has been looked at in randomized trials. And there are many controversial areas here that are in more recent times being ironed out. What about regional control for patients with sentinel node? Shirley, you asked a question about that a few minutes ago. And how do you treat the nodal basin? What about neoadjuvant treatment? That's what I'm going to talk about now. What about the extent of surgery? And then what about radiation, which I think we're moving away from adjuvantly. So here's very briefly some of the adjuvant trials. Ipilimumab against placebo is a very positive trial. So far, this is the only trial that has reported survival benefit. There's about a 9% difference in overall survival at 7 years using ipilimumab versus placebo. The problem with this study is ipilimumab was very toxic. It was used at a higher dose than we do in the adjuvant setting. So this has not become standard of care given the toxicity. So what about the other drugs? Nivolumab is better than ipilimumab in terms of recurrence-free survival. New England papers have shown this, the hazard ratio in and around 0.65, so 45% less chance that the disease will recover at 4-year follow-up. There's expanded follow-up compared on this study. And this is equally applicable to stage 3B, 3C, and resected stage 4. It's worth noting in the nivolumab study, they don't include 3A. What about pembrolizumab? Well, they do include 3A in this study. And this is a year of pembrolizumab against placebo for stage 3A to 3D and resected stage 4. And again, you can see a significant difference in terms of the investigational arm and the control arm for the primary endpoint of relapse-free survival. What about the targeted agents? Equally as impressive. A significant difference in relapse-free survival in the adjuvant setting with 1 year of BRAF and MEK combination versus placebo. An early interim analysis on survival looks like survival advantage will be seen. There's various statistical parameters have yet to read out about this. There is longer follow-up that has been studied in the BRAF and MEK strategy. And again, you can see the take-home message is a big difference in the two curves here in terms of relapse-free and metastasis-free survival. Very impressive figures at 4 years. This is Georgina Long, a prominent investigator in Australia. And at the recent ESMO meeting, 2020, she looked at longer follow-up in the adjuvant setting for all of the studies that I've just alluded to. Dabrafenib trametinib against placebo, nivolumab against ipilimumab, and pembrolizumab against placebo. It's dangerous to do cross-trial comparisons because not every arm is placebo and some trials don't include 3A. This is a very good slide. No adjuvant treatment, you can see the risk of recurrence at 5 years is 70%. And as you get onto the more modern treatment, immunotherapy, checkpoint inhibitors, and targeted therapy, you can see how the risk of recurrence reduces very significantly at 5 years and the risk of death also. So these drugs are very powerful in the adjuvant setting, and the updated relapse-free survival appears to be durable at 5-year follow-up in some of the studies. I'll skip that trial in the interest of time. So we've moved from metastatic to adjuvant, but what about neoadjuvant? To me, this is probably one of the most exciting areas for a medical oncologist in melanoma, and I would say for surgeons also. So even with the adjuvant treatment in stage 3C disease especially, and in those stage 3 with macrometastasis, there is still a significant risk of disease recurrence. So the 2-year relapse-free survival, 58%, this means 42% despite immunotherapy will recur. And you must remember in these adjuvant studies, 15 to 25% of patients potentially suitable were screen failures due to progression of disease already. So these are very sobering data, despite all of the good data that I've shown previously. So what about neoadjuvant treatment? Well, I think it's a very good disease to look at neoadjuvant treatment because it's so accessible in most cases. So we need neoadjuvant treatment because I've said adjuvant treatment, the survival, it's still not 100%, it's nowhere near it. Surgery, as was alluded to before by our Australian speaker, can be morbid. There are no biomarkers to guide prognosis in the adjuvant setting. There are no real validated biomarkers. We still use LDH. And we need to better understand the mechanisms of response. And a big problem in melanoma, despite all these new drugs, is resistance will develop in many cases to these new drugs. And of course, there's a precedent for neoadjuvant systemic treatment, NST, in other cancers. Upper GI cancers, all listed here. GI cancers, lower GI cancers, bladder cancer, breast cancer, many of these diseases routinely now give neoadjuvant systemic treatment prior to the main curative strategy, which is surgery. So also with neoadjuvant, you are able to tell, obviously, before giving any adjuvant, whether the patient has had a complete response, a near complete response, no response. That can be very valuable. So this model is very well suited for melanoma. So you've palpable nodes, stage 3 disease, you can do pre-treatment biopsies, you can do during treatment biopsies and then surgery, and you get an awful lot of useful tissue, biomarkers, correlates, clinical endpoints, etc. So the neoadjuvant landscape from nothing has started to become pretty busy in melanoma. There are many trials, early trials, you can see the N numbers here, they're small admittedly, but it's gathering momentum. And here's some of the trials very briefly. Small numbers, but these are the strategies. Neoadjuvant is short, anywhere between 3 to 12 weeks, and then surgery happens, and then adjuvant after that. So here's some of the pathologic complete response rates in some of these trials, admittedly small numbers, and I think you'd agree the pathologic complete response rates are very high. Some of these studies have been published despite the small numbers in high impact journals. So here's a very interesting study, the OPACA-NEO study, and the arm B in this study will be taken forward to another study called the PRADO study I'll talk about in a second. So it's looking at 6 weeks of immunotherapy combinations or in sequence, followed by surgery with the appropriate biomarkers either side. So here's some of the early results: relapse-free survival and pathologic complete response rates and AEs, etc. So in summary, arm B is the arm that fared the best in terms of toxicity and efficacy. So this is giving ipilimumab and nivolumab at these doses, 1 milligram per kilo and 3 milligrams per kilo in combination for 6 weeks with surgery. So relapse-free survival shown here, and relapse-free survival according to pathologic complete response rate. So if you had a near path complete response or a path complete response, the relapse-free survival is minimal. This is very close to 100%. Admittedly small numbers, admittedly high hypothesis generating. So this is published in the Lancet Oncology recently. And some of the data here in every arm, 47% PAT-CR, 57%, 23%. So as I said earlier, Group B is the arm that's going to be taken forward into the PRADO study that I'll talk about in a second. What about the neoadjuvant BRAF and MEK treatment? Again, small numbers. I've acknowledged this repeatedly. Small numbers. This is hypothesis generating, but the pathologic complete response rate, again, is very respectable with this strategy. And you can see the relapse-free survival is much worse if you don't have a pathologic complete response rate. And that's very powerful information to be able to tell a patient. So the early trials that I've mentioned show some promise, but we need to improve these outcomes quickly to advance the field. So pathologic complete response is a surrogate for overall survival in other cancers. This is well known in rectal cancer, in esophageal cancer, to mention only 2. Whether it correlates in melanoma is unknown, but I postulate that, you know, it will. So there is an international consortium that have pooled data from big investigators, big centers around the world called the INMC, and they have published white papers, green papers, etc., pathologic papers, looking at strategies for neoadjuvant treatment and looking at data that has been published to date. Here's some of the papers. So the platform that's used in many of these studies I've alluded to before: pre-treatment biopsies, during treatment biopsies, and then the dissection, then consider adjuvant treatment, the primary endpoints, and so on. So pool data from 6 of the studies I mentioned earlier have been published and presented. Actually, I don't know if they've been published yet. They've certainly been presented at ASCO as recently as this year. And the data has been reported using all these standard characteristics. And surgically resectable clinical stage 3 is the inclusion criteria. Nodal metastasis who underwent surgery were included. So admittedly, this is very selected, this population, but this is like everything in oncology. It's all about proper selection, selecting the right treatment, the right surgery in the right patient. This is how you get the best results. So the amount of patients who were ultimately included here was 184. And interestingly, the amount of patients whose disease progressed prior to surgery is not 0, but it is small. So here's some of the patient characteristics, 184 in total. Disease sites mostly in the axilla, then the groin, then the neck. Stage 3B and 3C mostly. And the PAT-CR rates are here. So complete response, 41%, and not a complete response, the rest. So here's some of the results. So relapse-free survival from surgery is respectable at 65%. By stage, obviously you'd expect 3B to do better than 3C. By drug class, it does appear from this data that immunotherapy does better than targeted therapy, albeit there are a lot of statistical boundaries being crossed here, so that's a bit of a sweeping generalization. What about by stage and drug? So again, immunotherapy appears to be better. What about by pathologic complete response? So if you have a pathologic complete response, irrespective of the strategy that's used, the relapse-free survival is very high. It's almost 90% with 2-year follow-up. Pooled analysis in longer follow-up shows the pathologic complete, if you have a PAT-CR and you've received immunotherapy, the relapse-free survival is 100%. So that's a really powerful figure, very hypothesis generating in my view. If you have a PAT-CR from neoadjuvant immunotherapy, a mere 6 weeks of treatment, 100% of the time at 2-year follow-up, your disease will not come back. And in targeted therapy, it's less. So again, further follow-up to reiterate the point bears this in mind. So the landscape is even busier now than it was in the earlier slide. Many different strategies are being looked at now in this neoadjuvant consortium and in other consortiums. There are many neoadjuvant trials currently accruing, and it's hard to believe this strategy didn't really exist 4 to 5 years ago. So here's some recent slides from ESMO, from Georgina Long. You can see again impressive 43% PAT-CR rates with immunotherapy, 47% with targeted therapy. What about comparing the two? I've talked about both strategies. This is why I mentioned adjuvant at the start and neoadjuvant. Well, there really is no strong data to show one is better than the other. This is the only trial that I know that looks at neoadjuvant compared to adjuvant. So very small numbers, but it does give a signal that perhaps neoadjuvant is better than adjuvant. So this is the 4-year update from Christian Blank in Europe, in the Netherlands, with this study. And again, it does appear to show a signal with very small numbers that neoadjuvant is better than adjuvant. What about the pathologic complete response? As I said to you earlier, this is very, very powerful information to be able to give a patient. Because if you have a pathologic complete response rate or a near pathologic complete response rate, the risk of relapse is very low. And this is the exciting trial now that I referred to earlier. So this is very, very interesting. So this is clinically stage 3B, 3C, or indeed recurrent disease. And I'm not going to go into the inclusion and exclusion criteria in great detail in the interest of time, but it's 2 courses of ipi-nivo, which is 6 weeks. And then you resect a previously marked lymph node. And in that lymph node, if you have a PAT-CR or a near PAT-CR, you don't go on to do a completion lymph node dissection. If there's a partial pathologic complete response, and that's defined, you do go on to do a completion lymph node dissection. And if there's no response, you do go on to do a completion lymph node dissection. And there are other arms randomizing after that. So that's very interesting, and this could potentially be practice changing. Clinical trial design is being discussed an awful lot in this setting of surgically resectable disease. Surgery first, treatment after, or immunotherapy first or surgery after. And, you know, this tests many different biological hypotheses. And I would postulate that it's better to give immunotherapy or targeted therapy with the primary or the melanoma still there, because you excite an immune response with the primary still being there. We know well that TILs, etc., are present when the melanoma is there. So TILs can be increased, and natural killer cells can be increased, all because of immune checkpoint inhibition and BRAF and MEK inhibition to a certain degree. But we need more biomarkers really above pathologic complete response. So there are a lot of work ongoing with interferon gamma signatures, mutation load, etc. And it does appear that some of these can correlate with relapse or no relapse from neoadjuvant immunotherapy and with response. So you can see here a very favorable signature correlating very strongly with response and relapse. So again, correlating strongly, no pathologic complete response is these signatures listed here. So another topical area that's a very interesting area is the microbiome. So it does appear that if you have a very diverse microbiome, this correlates closely with response and with toxicity from immune checkpoint inhibitors. So if you're a responder, you have a very diverse microbiome. If you're a non-responder, you don't. And maybe there are ways we can manipulate the microbiome. This is a very fascinating area of research. And this is being incorporated now into trials, looking at the microbiome at different time points during neoadjuvant treatment, surgery, and adjuvant treatment. So this is the model that's being looked at, whatever drug, neoadjuvant, completion surgery, and then follow-up. And so far, it does appear that the immunotherapy strategy is superior to the BRAF and MEK strategy, albeit this is not gospel. So Lots of work ongoing in this space, lots of work, lots of different strategies, and this is really a fantastic area to be in terms of research. There are so many correlates and so many ideas you could have with new drugs, new combinations, correlates for outcome, etc. So these are some of the new studies that are ongoing, looking at tyrosine kinase inhibitors that can potentially reverse PD-1 resistance, HDAC inhibitors, LAG-3 antibodies. This is the perfect platform for looking at new drugs combined with, in these cases, immunotherapy. So does neoadjuvant therapy work? Well, I think it does. It does appear to correlate with progression-free survival, albeit in small numbers. Is it better than adjuvant? Well, we don't know that. We need more randomized studies to look at that, but early signatures or early studies would suggest possibly yes. It certainly is a very efficient translational research platform. There's no question about that, and drug development platform. So this is Georgina Long's slide from ESMO. I've just mentioned relapse-free survival. It does appear to be maintained in time in adjuvant. BRAF targeted therapy versus anti-PD-1. What's the best? We don't know for sure. And there are many unresolved questions in the adjuvant setting. So what about the focus of this talk, neoadjuvant? Well, there are many different studies ongoing. There's not a uniform trial design. I think we probably need that going forward. Does pathologic complete response rate correlate with overall survival? We don't know, but it does appear to correlate so far with relapse-free survival. And large randomized trials comparing the adjuvant and neoadjuvant strategy are certainly awaited. And as I've said in an earlier slide, it's a very good platform to look at translational research and to look at novel drug combinations. So my final slide is, I think this is an exciting area of research, neoadjuvant. The regimens are very active. There's very high PAT-CR rates. And I think this will be a correlate for overall survival, but we don't know that yet. And it's probably going to be a new benchmark for rapid drug development and regulatory approval. And probably one of the most powerful things I can say in this talk is so far a 2-year follow-up. If you have a PAT-CR or near PAT-CR with neoadjuvant immunotherapy, the relapse-free survival is 100%. I mean, that's a very powerful statement. So thank you very much for your attention.
Derek, thank you very much. That was a tour de force in melanoma medical oncology. You must be the envy of all other medical oncologists, because it's good to be a melanoma medical oncologist at the minute. There's so much exciting stuff happening. So in the interest of time, I just have one question, and based on the fact that we have a surgical audience, given that you're giving neoadjuvant treatment before surgery and you're altering the immune system, is there any evidence from the studies that there's a change in terms of surgical outcome? Is surgical dissection more difficult? Are the complications in terms of wound complications or anesthetic complications or anything like that different after giving neoadjuvant treatment?
Well, that's a very good question. So from talking to my surgical colleagues, I mean, you must remember the numbers of patients who've undergone this strategy is very small to date. But we have done a kind of a type of neoadjuvant treatment, and I'm sure you've seen many patients who have clones that grow in the setting of metastatic disease, for example, an adrenal gland, a lung nodule, etc. And the simple thinking is to resect the resistant clones. So this is a type of neoadjuvant treatment. So I've been involved in many, I'd say 20, 30 patients over the last 5 years where that's happened. And I haven't heard of any anesthetic complications. Wound healing, no. I suppose the proviso with that is there's always risks of pneumonitis with immunotherapy, and you have to be quite careful in operating on the lung in somebody who's had immunotherapy. But certainly in other sites, abdominal surgery, bone resections, brain resections, and so on with metastatic sites that have grown, I've yet to see any anesthetic or post-operative complications. In terms of the surgeon's experience with resecting disease that has been exposed to neoadjuvant systemic treatment, you know, I haven't read anything in the literature where surgery is more difficult. In fact, it sometimes becomes somewhat easier, and that's a relative term, for the surgeon to see disease that looks like it's responded. It becomes intraoperatively a little bit clearer if disease is responding or not. You know, if nodes are chunky and very pathologic looking, that, you know, it's probably not responding. And if nodes look a little bit more necrotic and inflamed, probably are. But I mean, that's a very personal comment there. So I think this is a safe strategy with surgery. I haven't heard any adverse outcomes.
Great. Okay. Thank you, Derek. Thanks a million for dialing in this evening.
Sorry for the IT issues.
Don't worry. I might hand back to Margaret and Ronan to close out.
Shirley, thank you very much. I mean, I think all our speakers were just superb, and thank you for moderating it. Conor, I think you've asked a really important question and provoking question about the access to adjuvant treatment. I think it's an important one, and well done for asking it, and the best of luck with your own future treatment. Shirley, I think the questions you were asking of Michael at the end, I mean, his talk was superb, but the questions, particularly head and neck and sentinel node, the role of it, I think they were the questions that a lot of the audience would have had themselves and felt, and that they were very specific and really helpful. And Derek, obviously, with your expertise, I mean, it's been, I think when you said it was an exciting time, I think that has to be the understatement of the evening or the year, maybe. It's you know, having worked through the kind of onset of the adjuvant treatments, and to be on the thrust of this kind of whole neoadjuvant, I mean, it's just going to change the whole disease. It's fascinating being to hear it, but never mind being involved in the research. So thank you as well. Shirley, I'm sure your research is just going to be amazing when we kind of hear from you next in the next 5 or 10 years. It's going to be great. So thank you all for participating, and thank you everybody for joining. Rona.
Thank you. Thank you.
Thank you all. And it just remains for me as president to thank everybody presenting. Conor, we wish you all success in your final exams, and we look forward to seeing you as a surgical registrar and maybe even a consultant in due course. And I'm just minded to tell you all that when I was a medical student, I spent a summer in Malta. I occasionally went to the hospital, and there was an old Professor Evans there, and he was giving BCG to patients with metastatic melanoma, and we thought he was cracked. How things have come full circle with immunotherapy.
Very much so.
Good night all, and we look forward to seeing you next week.
Okay.
Thank you. Good night. Thank you.